We're
Ready?
good.
Does that look good to you?
Yep.
Okay, go for it then.
Good afternoon. I'm very excited to speak a little bit this afternoon about two topics that are incredibly important to me as a researcher and a clinician: neurodevelopmental and psychosocial predictors of quality of life in our CHG survivors. And my disclosures, probably the main one is I've created the pediatric cardiac quality of life inventory, which you hear a lot about, but it is free to be used clinically as well as for research. So when I trained 20 years ago, upwards of a quarter of the kids that had pediatric cardiothoracic surgical operations died in their initial surgical hospitalization. Today, nationally, it's down to 3.2%, and at Lurie, we're actually down to 1.5%, the second lowest operative mortality of any of the large high-volume programs in the country. So the bottom line is today, if you have heart surgery, you're not going to die. The strong likelihood is that you will survive, but with specific morbidities. So this conceptual model I created about 20 years ago now. We know there are a group of kids with pediatric, cardiac, and congenital heart diseases that, based on disease complexity, will have various medical, surgical, and catheter-based therapies. As we said, only 1.5% of those children will die at Lurie Children's. 98.5% will survive with neurodevelopmental, psychosocial, and physical morbidity. And what I've shown through some of my research and others have shown is that clearly impacts your quality of life. Now, when I was training 20 years ago and I was getting my master's degree in clinical epidemiology and biostatistics, I took a course in measurement and health, and there was no quantitative way at that point to assess quality of life in kids with congenital heart disease. So I set out my master's thesis to create an actual measure, a tool, a questionnaire that would actually quantitatively assess that quality of life and show that it was reliable, valid, responsive, and generalizable. So what is quality of life? Quality of life describes a child's ability to function in situational context and derive personal satisfaction from doing so. The three domains of quality of life include physical health and physical functioning, social functioning, and psychological functioning. As you can imagine, your brain's involved with physical functioning from a motor standpoint, and clearly from a social and psychological functioning, it's all brain. So when you think about quality of life, all three domains of your quality of life are impacted by your brain function. This is our initial validation paper back in 2010 showing the reliability and the validity of our disease-specific pediatric cardiac quality of life measure. In the PCQLI, it has a disease impact and a psychosocial impact subscale score. The disease impact subscale score involves physical health and physical functioning, max score of 50. Psychosocial impact subscale score is a max score of 50, involving social functioning and psychological functioning domains. A higher score is equal to a higher quality of life with a max score of 100. We enroll patients at 16 U.S. sites and 3 in the UK for a total of more than 3,000 patient-parent pairs and 6,000 respondents. This is the largest quality of life data set ever put together for any pediatric chronic disease in the world. We've learned a lot from these studies. I'm summarizing a lot of work here from a lot of people, which I want to thank. What we found out specifically was quality of life in CHG survivors is lower than heart-healthy children. Quality of life in CHG survivors worsens with increasing disease complexity as you go from two-ventricle disease that did not require surgical or catheter-based procedure, worse, two-ventricle that did require a surgical or catheter-based procedure, to the worst being single ventricle requiring 3 palliations for surgery. Increasing medical care utilization is associated with lower quality of life in CHG survivors, and there's wide variation in quality of life score within cardiac subgroups. It's a very important moment for us when we were looking at the pediatric paper validation data. It's 1,605 kids in the U.S. I pulled out the kids with AS, with the Charlie Flo and Fontana, and what we found was, while the average scores were in the 80s, 70s, and 60s, the ranges were huge for child respondents, parent of child respondents, adolescent respondents, and parent of adolescent respondents. The questionnaire here is for 8 to 12-year-olds, for the adolescents, 13 to 18-year-olds, and as you can see, you could be a Fontana of a score of 100. You could be a Fontana of a score of 30. And what that told us was that ultimately when you're born into a specific subpopulation of CHD, that you're, as a group, likely to have a specific score decile. But depending on what resilience factors you have or depressant factors you have, you may have a very different quality of life. We then published a paper last year looking at surgical complexity. So what I described before was disease complexity, two ventricle, no intervention, two ventricle intervention, single ventricle. But there are certain operations, obviously, that are much more complex than others that are more likely to have specific morbidities and complications after their operations. So what we found was that surgical complexity assessed by RACS-1 category and Aristotle basic complexity score. People know what those are? So have you heard of STAT categories more recently? So STAT categories by the STS, the Society for Thoracic Surgery. STAT 1 is the lowest complexity. STAT 6 is the highest complexity. Generally, STAT 5s and STAT 6s are truncuses, intravenous gorges, and stage 1s. And ASD would be a STAT 1 category. The RACS categories, which preceded the STAT categories, basically were the exact same way. Lowest RACS category, low complexity, high STAT category, high RACS category, high complexity. Your ADC Aristotle basic complexity score, right, was basically 3 to 14. The lower the score, the lesser the complexity. What we found was, when we looked at, again, the sample of 1,605 patients, is that your actual surgical complexity as assessed by the RACS-1 category and Aristotle basic complexity score, which are very similar to STAT categories, only accounted for 2% of your actual variation in quality of life score. 2%. If I had an ASD, or I had a stage 1, didn't matter, 2%. Now, there are lots of other things that matter, which I'll get to in a second, but when you control for lots of other things, a very small amount actually produces quality of life. Now, surgical and intensive care unit factors only accounted for 10 to 50% of variability in survivors who are 8 to 18 years of age, and included great number of surgeries, as well as great number of ICU admissions, but those two obviously are collinear, meaning that it's a very high correlation between number of ICU admissions and surgeries, because for every surgery you had an ICU admission. A great number of inotrope days, so how many days were you on epi, milrinone, vasopressin, and then post-operative neurologic deficit persisting in discharge. Those were highly correlated with the worst quality of life, but again, only accounted for 10 to 15%. So if it's not surgical complexity, if it's not surgical and ICU complications, then it has to be neurodevelopmental outcomes, psychosocial morbidity. So at that point, we said, okay, if this is indeed true, that it's really not what's happening in the OR and the ICU, then it's got to be these longer-term issues. So neurodevelopmental may be your intelligence, your academic achievement, maybe your neuropsych functioning, your gross motor functioning, your behavioral functioning. There might be characters in the environment, family functioning, parental stress, post-traumatic stress in the parent, trait anxiety in the parent, or depression in the parent, parental coping style, or characters of the individual patient, self-perception, behavior, post-traumatic stress, trait anxiety, that may impact quality of life. And then we would then set out to say, okay, what might those factors be? So what is the actual phenotype when we talk about this neurodevelopmental phenotype? So, and this is summarized in our AHA AAP guidelines paper from 2012. And this is from literally dozens and dozens of single center and some multi-center studies, kind of pulling all that together in our complex CHG survivors. They typically have mild cognitive impairment with normal to slightly lower IQ and academic achievement. So if you look at, remember from nursing school when you took your stats class, the normal distribution, bell-shaped curve, right? Two, right? You remember?
Yes.
Yeah.
We try to forget it.
Try to forget it. In this moment, it will actually be important to you. Remember how there was 2.5% in one tail, 2.5% in the other? There's 95% in between. In kids with CHD, if you who are survivors, you take that bell-shaped curve and move it to the left. Okay. On average, their IQ is normal in the 90s. Academic achievement is normal. But instead of having 2.5% in the tail, you have 30%. So 1 out of 3 kids will have a low IQ or low academic achievement. They'll have impaired traumatic language, decreased visual construction perception. You guys know what visual construction perception is? So imagine you're a second grader and you're learning about circles and squares and triangles. Should be 3 squares and a circle on a piece of paper and say which one is not like the other. You can't tell the difference. So imagine now you've got, you're learning your letters, learning your numbers, learning arithmetic computations with division signs and multiplication signs and addition, subtraction. Very difficult for you to learn those skills. Poor executive functioning. So all of you made 1,000 decisions last night to get to work today on time with everything that you needed, have everything at home taken care of, to stay here late tonight, which I appreciate, for this lecture, so you can get home a different way or a later train and do what you need to do at home later tonight in a different way. That's executive functioning. It's planning to achieve a certain end game, whether it be a project or how you organize your work or your life. Inattention, increased impulsivity. These kids have a higher risk of ADHD. They have diminished fine and gross motor skill, and they typically have psychosocial maladjustment with internalizing problems. Internalizing problems are typically anxiety, depression, withdrawal symptoms. This phenotype, these specific deficits or delays may be mild, but often occur across multiple domains. This high prevalence, low severity picture doesn't meet the classic criteria of learning disability. Many of these children have difficulty in school, but may not qualify for special services. State of Illinois, there are certain boxes that you have to check to get specific services in school. There's no CHD box. There may be in the future, but right now there's not. So the only way that you can get services is by justifying to the school that you fit some other box, or the other box that they deem that child wants, either an IEP or 504, to give learning support so they can achieve the truest potential. That went one for the list.
I think a right click maybe?
Yeah.
Okay. What's the psychosocial phenotype? They've impaired social interactions, deficits, and social cognition. So all of you, when you walk into a room of your colleagues, have your antenna up. And you can tell who's in a bad mood that day, who's in a good mood that day, who is hungry, who is the last thing I want to do right now is meet with you, who is really interested in what you're saying and is really on your side and really wants to help you move that agenda forward. Not a word is spoken, and you can tell all those things because you've got great social cognitive skills. Kids who are CHD survivors because of white matter injury typically don't do well with that. So if you think about, I said when I was attending in Cincinnati, the waiting room for the clinic used to be right outside where our offices were before they remodeled everything. So I'd be walking through the clinic all the time to get to my office. And I remember walking through one day, and I saw these 3 girls playing in the corner, and one was a Fontan, and one was a sister of someone else, and another girl was like an ASD or something. And the heart-healthy child and the ASD child, they were having this conversation, they were interacting, in this dollhouse and making up these stories, and the Fontan child had a really hard time following the interactions, knowing where to chime in, knowing how to chime in, and it's that inability to have that social cognition that early on looks like isolated play and then can become bullying when you get to high school. They've impaired core communication skills, a higher incidence of autism spectrum disorders, increased incidence of psychiatric disorders, depression, schizophrenia, issues with behavioral emotional function, specifically anxiety, depression, and post-traumatic stress. So this is from our original pediatrics paper 2010. We looked at correlations between self-perception, internalizing problems, and what we found was if you had better self-perception, you had better quality of life. If you had more anxiety, depression, withdrawal complaints, somatic complaints, you had a worse quality of life. We looked at the Achenbach DSM-oriented scales, which are basically screeners for potential psychiatric issues. And if you had more symptoms in the affective, anxiety area, or ADHD symptomatology, you had a much lower quality of life. We pulled a cohort of 143 patients back who had TGA, arterial switch operations, transition surgery, tetralogy of Fallot surgery, and Fontan palliations. They were on average 11 years of age, 2/3 male. They administered quality of life scoring, behavioral emotional function testing, gross motor skill, and did a full neuropsych battery looking at most of the things we just talked about. These patients' quality of life scores were depressed. Here's the PCQLI disease impact subscale score, remember physical functioning, psychosocial impact subscale, and then the PCQL school subscale score. PCQLI scores, the subscale scores out of 50. You can see that these are depressed in the mid to high 30s. For the school subscale out of 100, they scored in the 60s. So for these 143 patients survivors of Cincinnati, they clearly had lower quality of life. When we looked at all the variables, and it's too much to go through in this lecture, we found that motor issues occurred in twice the population average, anxiety, depression in twice the population average, and executive dysfunctioning 3 times the population average. And that these 3 factors accounted for half the variation quality of life score. So remember before I said surgical complexity, 2%. Surgical and ICU complications, 10 to 15%. Half the variability is explained by those 3 variables. When we looked at the PCQL school functioning and the CBCL Achenbach school competence scores, 1/3 to half variation scores based on executive function. Demographics and anatomy only counted for 2 to 8% of the quality of life scores. So knowing that psychosocial quality of life scores for these patients was lower than normal, we then set out to say, well, we know the complexity, remember mild CHD without intervention, two ventricle heart disease with catheter surgical-based intervention, or single ventricle, that was associated with worse quality of life. But those we thought were direct effects. What were the indirect effects from the psychosocial factors that might be driving that association? Because obviously, the single ventricle patient's going to go through a lot more psychosocial potential issues than the child who had the ASD, a single repair, or the kid's got a bicuspid aortic valve who comes to the cardiologist every 2 to 3 years. So I apologize for the small print, but I think this is very instructive. This is new data we just submitted for publication at Journal of Pediatrics. The outcomes here are patient, PCQI, psychosocial impact score, and parent proxy reported PCQI, psychosocial impact score. You guys understand what I mean when I say parent proxy? So the parents filling out a questionnaire asking them about their child's quality of life.
Yes.
Versus here is just the child responding on their own quality of life. Half of the variation in score in psychosocial impact subscale score was explained by these variables here for the child, and for the parents, half the variation. So for the child, what were those things? Self-perception, worse self-perception, more internalizing problems, so anxiety, depression, more anxiety, and more child PTSD. All 4 of those factors predicted a worse quality of life score. If the patient had a special education plan, an IEP, worse quality of life. For the parent, if the child had more internalizing problems, if the child had PTSD symptoms, if the parent had PTSD symptoms, if the parent had sought mental health treatment in the past, if the parent had increased parental stress based on having a child with chronic disease, all of these things predicted a worse quality of life and accounted for half the variation in the PCQLI subscale score for psychosocial impact. Okay, well, if you don't believe me, let's look at a specific population. So let's look at the Fontans that we pulled out from our UK-US data set. There are 300 of them. 2/3 male, again, mostly Caucasian, mean age is 12 years of age. Half at lateral tunnel, half at external conduits. A quarter of them had learning supports, 20% of them had special ed, and another 30% had individual education plans. 16% of them had pacemakers. Sorry, it's busy, but this is very helpful. Here's anxiety. Here's the patient's perception of their quality of life against psychosocial impact. Here's the parent perception. If the child had increased anxiety, right, they had a much lower quality of life score. If the child had significant anxiety, they had a much, much lower quality of life score. Look at that, negative 0.67. Okay. Family environment, not so important. Post-traumatic stress in the patient and the parent, significant negative correlation. Parental stress, significant negative correlation. If there's more parental stress, lower quality of life. So now when we think about these issues, while I'm going to constantly in the OR and in the ICU try to do interventions that will prevent that neurodevelopmental phenotype of that white matter injury, really what we need to focus on interventions for neurodevelopmental psychosocial phenotype treatment for kids that have specific neurodevelopmental psychosocial morbidities, because I've just shown you they significantly impact quality of life. So if we want to nurture psychosocial resilience, improve quality of life, we need neurobehavioral psychotherapy in the child and the adolescent to minimize the impact of social cognition issues, psychiatric issues, autism spectrum and affective disorders, and ADHD. We need psychosocial support to have the child improve their self-perception. We need therapy in the patient and parent to prevent and treat PTSD symptomatology prior to invasive procedures in the ICU and during follow-up. We need to prevent and treat anxiety and depression. We need programs to reduce parental stress relative to raising a child with chronic disease. So, after 12 years of doing this research, several of us got together nationally and said, okay, we know all these survivors having these issues. We now know that it's impacting quality of life. We need an actual guideline, national guideline that's going to talk about how we should evaluate and manage these specific issues. So myself and Bill Maley co-chaired this writing group. This was a 2.5-year process. Came out in 2012. Within the first 2 months, it was out at 34 million hits on the internet. So it's one of the most cited pediatric guideline papers as got pediatric cardiovascular disease. So in this paper, we identified who was high risk. So if you were a neonate or infant that had open heart surgery, if your child with other cyanotic heart lesion not requiring open heart surgery in the neonate or infant period, so a child with Epstein's anomaly, for example, a chronic cyanosis, a child with temporal martusion mapkas that did get an operation in the first year, then got palliated after the first year of life. A single ventricle child that may have gotten initially a PA band and they got a Glenn off bypass and didn't get their front tangent. Again, a small population of patients, but these are patients with chronic cyanosis who didn't have a pump run. And then a large group of patients with CHD and other comorbidities, including prematurity, developmental delay recognized in infancy, suspected genetic abnormality or syndrome, history of mechanical support, ECMO and or VAD, heart transplantation, CPR at any point, prolonged hospitalization greater than 2 weeks. Jane Newberger's study, she found that if you, for every day you're in the hospital in the Boston Circuit Torres trial, beyond 14 days, your IQ was low by 1.3 points. Now, the issue is not that we do things to patients that injure them, and that's why the IQ is low beyond 14 days. It's that patients who have to stay beyond 14 days after a switch are clearly not typical to the normal child that will get out before that. They have higher morbidity, they have more complications. We know this, the longer you're in the ICU, the more opportunity there is for complications, whether it be thromboembolic emboli or air emboli, but the bottom line is they're at higher risk. Preoperative seizures related to CHD surgery. The 16-year follow-up showed that the most important factor that predicted neurodevelopmental outcome at 16 years in that cohort from 1988 to 1992 was did you have seizures? What percent of seizures that actually happen in our patients do you actually see? Very small percentage of them. Up to a quarter of our patients are seizing post-op, most of which we don't know about.
Right.
So one of the things that Mark Wainwright and I are working on is we want to have every newborn that comes back be on an EEG that first post-op night to see if there's any seizure activity that we actually treated effectively. Because we know that as an outcome, if you have seizures, preoperative seizures, it does give you a worse outcome. Obviously, significant abnormalities on neuroimaging and a microcephaly, small brain. So if you have strokes, PVL, other neuroimaging issues. So here's the actual algorithm. This part up here is the 2006 AAP Developmental Pediatric Recommendation for Surveillance and Screening. What we did was we said here we're going to add on that if you're high risk, you come down here and you have, if you're high risk, without screening, you go immediately to formal medical and developmental evaluation. And again, the idea is surveil, screen, evaluate, manage. So, how should we care for children with heart disease and their families long term? Can primary cardiologists handle this? No. We literally, will spend 10 minutes with a patient. My colleagues don't ask how is school going. They don't ask how's your child doing at home. Are they anxious? Are they depressed? Do they have ADHD? It's what's your Lasix dose? Do you need more afterload reduction? And I'll see you in a year. Your echo looks fine. So we need cardiac neurodevelopmental programs to see these patients. This is our program. Our goal is to monitor and intervene on development. I was brought here to build this. Ray and Derenay had built a very nice birth to 5 program for the neonates, for the NICU babies. When Winston was here, he started getting the CSU kids into that clinic. We now have birth to 18. We piloted our school-age clinic from 6 to 18. A month ago, we've done 2 pilots so far, 2 more this summer, and then we'll open officially after Labor Day on the 12th. We expect to see about 250 to 300 patients a year. We have 1,000 patients right now. We've had surgery here in the last 15 years that would be considered high risk, that need to be evaluated, and that's not talking about any of the babies who are going to graduate, which is about 50 to 75 a year from the baby program, or all the patients from all the other pediatric cardiac programs in the city that may want to come and be evaluated as well. So we're expecting basically a tidal wave of patients to come, and we're trying to build it, sit, stand, walk, jog, run, because we can't be need everyone to start. We're going to take care of our patients a little bit first, but ultimately I hope that we can see patients from other centers. So, cardiovascular care and neurodevelopmental and psychosocial support really has to be across the lifespan. We see patients in the fetal priority second opinion clinic. We talk to families about neurodevelopmental psychosocial issues in that clinic. We have our perioperative care. Then we have our NICU cardiac developmental support program, and then our cardiovascular bridge programs, where they get transitioned appropriately over to NM for their adult care. So comprehensive cardiovascular care and neurodevelopmental psychosocial follow-up is required for this population of high-risk patients. This is an important article that came out last year in Circulation from Marino, one of my colleagues. We talk about neurodevelopmental burden and congenital heart disease when the kids are young. When they become 18 and one day year of age, the neurodevelopmental issues have not gone away. They now become not neurodevelopmental burden, but cerebrovascular lesion burden. And as you age, your likelihood of having strokes and other secondary cerebrovascular events is higher because we manipulate all their head and neck vessels quite a bit when they're young, especially our Fontans. And they've acquired cardiovascular disease. So it's not like when you become an ACHD patient that it stops. It just now transitions into a not neurodevelopmental but neurocognitive set of issues and a potential cerebrovascular burden moving forward. So when the guidelines came out, a bunch of us from the guidelines committee started meeting on a regular basis. And over 5 years, we went from annual meetings at different centers to last year, we got a 501c3. The Cardiac Neurodevelopmental Collaborative was born, it's incorporated. This is the organization nationally now that is trying to improve both the clinical systems and processes we provide in these neurodevelopmental clinics, as well as do cutting-edge research that's going to show interventions that will improve neurodevelopmental psychosocial outcome. There are 28 centers in the country right now that are involved. We are one of them. I co-chair it with Jackie Sands from DC Children's. 9 out of the top 10 children's hospitals by U.S. News have cardiac neurodevelopmental programs, and it's expanding. Here they are. 3 countries, 20 participating students, 350 members to date. The 7th annual meeting is coming this summer in June in Kansas City. I'm leaving for the World Congress on Friday. For the first time ever at one of the World Congresses, there'll be a pre-symposium on neurodevelopmental psychosocial outcomes next Sunday, which will be very well attended. So in summary, quality of life in CG survivors is lower than heart health for children and worse with increasing CG collective. There's wide variation in quality of life among CG survivors. Quality of life in CG survivors is strongly associated with neurodevelopmental and psychosocial deficits, including executive dysfunction, worse self-perception, internalizing problems, depression, withdrawal, affective disorders, ADHD, increased post-traumatic stress symptomatology in patients and parents, trait anxiety in patients and parents, and parental stress. Interventions are needed to prevent and treat psychosocial issues in complex CG survivors and their families to improve the patient's long-term quality of life. High-risk cardiac patients, per the AHA-AAP guidelines, should be referred directly for formal developmental and medical evaluations to assess the neurodevelopmental psychosocial status of the patient and the parent. And these interventions may be performed during the prenatal period in the ICU by integrated